Thank you very much for this opportunity to share this talk today. So I'm going to just give you an overview regarding the genetic diagnostic of neurodevelopmental diseases, some challenges and perspectives. So the developmental disorders, also known as a DD, they are disorders that are characterized by severe and chronic disabilities attributable to mental and or physical impairments in childhood. Most of the DD they have impact on the adaptive function in all three major domains, and these domains include the conceptual skills in the language and the reasoning and memory. There are also those affecting the social interpersonal skills, and others the practical functioning of self-management and the personal care. When you look at the causes, the genetic causes of DD are predicted to be present in 25 to 50% of diagnosed cases. Moreover, more than 50% of children with severe DD of probable genetic origin remain without a genetic diagnosis using classic techniques like karyotype or other chromosomal microarray. And even the recent study have shown that we need just to use the more advanced techniques just to be able just to identify the majority of DD with de novo mutations or new genes, yes, causing these disorders. Well, when you look at the prevalence, we see that most of the DD they are characterized by slower learning, and the attention deficit hyperactivity disorders more common in these disorders. Language disorder and the speech with speech delay, speech impairment. It's also most of the clinical characteristics of the DD. And even more patients, they present a global development delay, intellectual disability. Autism spectrum disorder is also found in most of the DD affecting the childhood. And permanent sensorineural deafness is one of also the signs that we find in these disorders. Well, there are two groups that we see that these disorders are being classified. So there's a group of externalizing disorders, which is characterized by outward directed behavior, where we found the non-compliance, aggressiveness, hyperactivity, and impulsiveness symptoms. And this includes especially the ADHD, conduct disorder, oppositional defiant disorders, and among others. And most common disorder we have here is the Fragile X syndrome, which is the most common intellectual disability disorder in boys. And then there's a group of internalizing disorders where we see the disorder being characterized by inward focused behavior, where patients they try to express this depression, anxiety, social withdrawal, and it includes childhood anxiety and mood disorders. And the more common disorder here is the Rett syndrome, which is commonly found in girls. When we use the DSM-5 childhood disorder tool, we have different characteristics, different groups. There's a first group, which is a group of intellectual disability. In this group, we found the Fragile X syndrome, which is most common inherited form of intellectual disability, and with a high prevalence in boys and girls, where you see the patient that are being characterized by dysmorphic features, large head, endocephaly, long face, chin, forehead, chin, ears, and behavior problems characterized by hyperactivities. And we also have in this group the most common chromosome abnormality, which is Down syndrome, most common in Africa as well, where the patient, they have, of course, the intellectual disability and a variety of dysmorphic features that are being characterized in childhood, especially by psychomotor development delay. In this group, there are also other syndromes that we see with autosomal recessive condition or X-linked condition. And then there's another group of specific learning disorders, which is characterized by neurodevelopmental disorder that begins by school age. In fact, might not be recognized until later. However, 5 to 15% of school-age children struggle with learning disabilities. So we see there's a delay, school just learning disability, and a delay characterizing these children at this age. And then there's a combined group of autism spectrum and ADHD disorders, where we see the global learning difficulties, specific learning difficulties characterized by dyslexia, dyscalculia, dyspraxia, which is characterized by coordination difficulties of movement, speech delay disorders, and tic disorders. And then there's another group of motor disorders. These disorders are characterized by the disorders of that cause abnormal and involuntary movement, like the ataxia syndromes, cervical dystonia, chorea, Parkinsonism, Rett syndrome. Rett syndrome in girls characterized by involuntary movements. This syndrome, the more progressive neurodevelopmental disorders, it can be diagnosed very late. So it's during the development of the child. So the symptom cannot really appear before 6 to 18 months, and then later you see there's a developmental stagnation and the regression of the development, and then the child starts just to have these motor disorders with involuntary movement of the fingers, the hands, as you can see here on the picture. And then we have the feeding and the eating disorders. In this group, we see the patient having symptoms characterized by persistent disturbance of eating and eating-related behavior that results in alteration of consumption or absorption of food, which lead to rumination disorder, anorexia nervosa, bulimia nervosa, and the most common disorder is the Prader-Willi syndrome. And this disorder is characterized by severe hypotonia, feeding difficulties in early childhood, and then later they develop excessive eating and gradual development of morbid obesity. And they also express the speech delay, speech impairment, cognitive impairment, and behavior problems characterized by aggressivity and other behavior problems. So more common disorder as well. And of course, there are other two groups characterized by disruptive and impulse control and the conduct disorder, and also a group of anxiety disorders, which is more mental disorder, characterized also by hallucination or depression. Well, this GDD group, the disorders, they present a diagnostic challenge. When you look at on a genetic background, so there's a trend to be influenced, to have an influence on DD, and which is related to these challenges. The chromosome and the gene disorders, for example, the Fragile X anomaly occurs in 2 to 3% of children with autism spectrum disorder. And when you look at this autism spectrum, they have 5% of elevated risk for chromosome abnormalities. And about 25% of children with, for example, tuberous sclerosis disorder, they have autism spectrum disorders. And when you look at them in the diagnosis, only 50% of DD can be diagnosed using the classic routine techniques like a karyotype, Sanger sequencing, CGH, and others. And then there's a big proportion of DD disorder that are not really diagnosed using this classic routine. So that's how we need a more advanced techniques like NGS to be able just to diagnose these disorders. Well, the recent study, UK study, which is DDD study, Dicephalic Developmental Diseases, have been able just to detect the genetic causes of the DD disorders by using the whole exome sequencing. So they screened more than 4,000 DD families, which were most of these patients were characterized by the intellectual disability, the DDD, epilepsy, autism spectrum disorder. And then they have been able just to identify de novo mutation, and 30% to 40% of cases have been just confirmed. So this just showed that different regions that were just detected as a new, and they could just identify new candidate genes and mutations which were not characterized when they were using the classic techniques. And this just showed that how we can just diagnose the DD by NGS and also be able just to identify new loci or new genes. So here you can see a number of CNV or even genes that have been related to development delay, growth delay, and also speech impairment. This was very contributive study, which allowed us to identify new genes that are related to DD disorders. In our setting in Rwanda, when we started just to provide the medical genetic services almost now 15 years ago, so we have just conducted a study now 7 years ago on identification of DD genetic causing by using the RCGH analysis in a patient who were presenting development delay, intellectual disability with multiple congenital anomalies. So several chromosomal rearrangement, duplication, deletions have been identified in this group. And then we remained, of course, with a group of patients where we could not just identify any genetic causes using these techniques. And then we later selected this group to use, to make analysis of genomic analysis of the unidentified variants. So you can see here there are three families of interest that we studied here. The first two families are consanguineous families, and the third one, all of those, the third one is not consanguineous families, but all of those families, they had just in common some characteristics, clinical characteristics characterized by communication disorders, autism spectrum, learning disorders, motor disorders, ADHD, or intellectual disability. So the aim of this study was just to identify the pathogenic variant responsible for neurodevelopment disorders in these families using whole exome sequencing. So, of course, as I mentioned, the prior analysis were negative. The chromosomal microarray was negative. And that these are our patients. You can see here, they were similar to previously published patients where some mutations have been identified. So, but for this group, we could not just identify the same mutation like the similar patient here published previously. And then we identified a mutation in this group of patients. So there's a VPS 51 biallelic variant, which was just causing the microcephaly with brain malformation in most of these patients, especially the two families, consanguineous families, where the patient turns just to have similar symptoms. So this was just the first time to identify these variants in such type of patients. So in conclusion, so establishing a genetic diagnosis of for the development disorders has numerous implications beyond just medical treatment, and they should be considered as a priority for patient care and for discovery of novel genetic causes and the mechanisms, like the de novo mutation or inherited mutation. And of course, the African founder mutations also can be found. Non-causative mutation related to DD, also another interest, a benefit, and the frequently mutated genes in clinical subtypes of DD. Given the diagnostic rate of genetic testing and the potential for clinical and personal utility, there's a consensus that genetic testing should be offered to all patients with global development delay, intellectual disability, and or autism spectrum disorder. And of course, this needs just to create a network and a collaborative with collaborative groups for addressing the issue of accessing the next generation sequencing techniques, which are not available for most of the African countries. And this can just be a solution for how we can diagnose the DD in Africa. Well, I want just to thank most of my collaborators from Europe, the Center for Human Genetics in Liège, and who are just supporting the initiative for DD studies in Rwanda. Professor Kati and Kati Anastos and Phil Casso from Albert Einstein College of Medicine in New York, who are just contributing for the biobank, and the others like Professor Johnson Muschlegel and Janet Watke, who are supporting the diagnostic testing, and of course, my colleagues from Center for Human Genetics. Thank you very much for your kind attention.
Thank you very much, Amadou.
Sorry, I was having a problem with my microphone. And thank you very much, Leon. And we'll proceed to the next speaker. Our next speaker is Aissata. Aissata Toure from Mali. She is a research fellow based at the Neurogenetics Lab at the University of Techniques and Technologies of Bamako. She's currently a resident in neurology at the National Teaching Hospital, which is located at Point G. She has also an interest on hereditary neurological diseases. And Aissata is also a member of the neurogenetics domain and is currently working on the clinical and genetic aspect of spinal muscular atrophy in a Malian population. So please welcome Aissata Toure. She's going to talk now. Thank you very much.
Hello everyone, my name is Aissata Toure, student at the University of Sciences, Techniques and Technology of Bamako. It is a real pleasure and a great honor for me during this 13th conference of the African Society of Human Genetics about genetics of spinal muscular atrophy in the Malian population. As outlined, we will go through the background in which we will have a little detail on spinal muscular atrophy, then the objectives of this work follows. Spinal muscular atrophy is an autosomal recessive disorder characterized by the degeneration of the motor neuron in the spinal cord. It's due to the mutation of the SMN1 gene. The homozygous deletion of the SMN1 gene accounts for 98% of cases. It is the most common cause of autosomal recessive inherited mortality. Its frequency is lower in Africans compared to other populations, with an asymptomatic carrier frequency of 1 per 30 to 1 per 50 in European population and 1 per 209 in Mali. The clinical features include symmetrical progressive mesial atrophy and weakness predominantly proximal, absent reflexes more accentuated in the lower limbs, tongue fasciculation, hand tremor at rest, lower limbs, and spinal deformities. There are 5 subtypes from 0 to 4 classified according to the age of onset and the maximum motor function affected. There is not a lot of data on spinal muscular atrophy in Africa, precisely in sub-Saharan Africa. We report here genetically confirmed cases of spinal muscular atrophy in the Malian population. Our objectives are to clinically characterize families with spinal muscular atrophy phenotype and identify the genetic defect. Our study, approved by the Ethics Committee of Faculty of Medicine and Dentistry of Bamako, written consent obtained from the participants before their enrollment after a long explanation of the study course. Patients carefully evaluated by neurologists and other practitioners such as pediatricians, geneticists, and other specialists if needed. Socio-demographic data and clinical features were collected and mentioned in medical record. Blood tests including creatine kinase were performed to exclude other causes. DNA was extracted from the peripheral blood by using standard procedures. The quantitative PCR method was performed for dosage of SMN1 and SMN2 gene, which analyzes and examines exon 7 of each SMN1 and SMN2 gene, as well as dosage control gene. As a result, we had 5 families totaling 8 patients with spinal muscular atrophy features and consanguineous marriage in 3 families. Genetics analyses in 3 index patients show with homozygous deletion of SMN1 in all. 2 and 3 copies of SMN2 has been found in patients with type 2 SMA and more than 4 copies in those with type 3 SMA. The observation 1 concerns 24-year twin brothers from consanguineous marriage, pointing out the recessive inheritance pattern. They were seen for weakness in forelimbs started at 12 years old with fatigue when walking and difficulty climbing stairs. Clinical examination found more proximal weakness in forelimbs, absent reflexes, and no sensory loss. As shown by this picture, we can note a upper and lower amyotrophy, also tendon retraction in lower limbs. Genetic testing identified the homozygous deletion of the SMN1 gene with more than 4 copies of SMN2 gene, evoking SMA type 3. The patient went under physiotherapy with slow worsening evolution. Here in observation 2, we are 4 and 2 years old boys, referred for suspicion of muscular disease. Pregnancy and delivery were normal. There is no consanguinity, but both parents are of the same ethnic group. Symptoms started at 6 months with hypotonia and later with difficulties sitting with falls. He could not switch from lying to sitting himself. The pedigree showing 2 affected males and 1 suspected female from a non-consanguineous marriage with an affected parents, assuming a recessive inheritance pattern of the condition. Clinical examination found a normal cognition, axial hypotonia, scoliosis when they are sitting, generalized amyotrophy predominant in lower limbs, weakness with fasciculation, and absent reflexes. Genetics testing identified homozygous deletion of the SMN1 gene with 3 copies of SMN2 gene. The patient index died at 10 years old due to pulmonary infection. Our last observation concerned 3-year-old girl from consanguineous marriage. She was seen for walking difficulty, started at age of 4 months with hypotonia. She could not hold the head. This pedigree showing the affected patient from unaffected parents in consanguineous marriage, pointing out a recessive inheritance pattern. Clinical examination found a normal cognition, generalized hypotonia, accentuated dorsal kyphosis and scoliosis, absent reflexes. And then genetic testing identified homozygous deletion of the SMN1 gene with 2 copies of the SMN2 gene. This is the first such study reporting that high number of symptomatic cases of spinal muscular atrophy in Mali. Despite the low carrier frequency, our study shows that this disorder is not uncommon in Mali. Through the high frequency of type 1 described elsewhere, no case has been found in our study. This may be due, in one hand, to the low size of our cohort, and in the other hand, the delay of diagnosis. Patients die before being seen by a doctor. In conclusion, extensive genetic testing of putative cases may uncover many more cases, which could advocate for treatment availability in our country. Future genotypes-phenotype studies may identify other genetic modifiers. We cannot finish without thanking our partners, our participating families, and all the research team of Mali, especially thanks to Dr. Landouri.